Good afternoon, everyone, and welcome to today's webinar, Using Learning Communities to Support Innovation Adoption, Lessons from the AHRQ Healthcare Innovations Exchange. Before we begin, we'll take a moment to go through some of the technical instructions for today's webinar. The audio for this webinar is being delivered via your computers, and so you will need speakers or headphones to hear the audio. If you need an alternate method of accessing the audio, please submit a quick question through the Q&A pod, which is located in the left portion of your screen. We also want to let you know that if you have technical difficulties at any point, you can access live technical assistance by calling the number listed in the technical assistance box on the bottom left corner of your screen. We also ask that you turn off your pop-up blocker so that we can distribute the survey that will be at the end of the webinar. We would really appreciate your feedback, so we hope you'll turn that off and get back to us. Lastly, I wanted to let you know that you can submit questions at any time in the Q&A pod. The Q&A pod is on the left of your screen. You just type your question and click Send. We'll try and respond to as many questions as possible during the time allotted. This is intended to be an interactive forum, so we encourage you to submit those questions throughout the presentation, and we'll respond to them at the end of the webinar when we have time. With that, I want to turn this over to Mary Nix, who is with the Agency for Healthcare Research and Quality, the sponsor of today's event. Ms. Nix serves as the project lead for the AHRQ Healthcare Innovations Exchange. Welcome, Mary.
Thank you, and good day, everyone. On behalf of the Agency for Healthcare Research and Quality and Academy Health, I'd like to welcome you to our web event on the use of learning communities to support innovation adoption. I'm Mary Nix with AHRQ's Center for Evidence and Practice Improvement. We are very excited about today's event and glad to see that you share our enthusiasm. Turns out that we have over 800 registrants for our event today. So what is the Healthcare Innovations Exchange? For those of you who are new to the Innovations Exchange, or for those of you who have been with us for a stretch, I'd like to take a minute to give you an overview or refresher, as the case may be. Through a number of mechanisms, the Healthcare Innovations Exchange supports decision-making on potential adoption and implementation of health service innovations and tools. We aim to accelerate the diffusion and uptake of novel care delivery strategies that improve healthcare quality, with an emphasis on those that reduce disparities. We also aim to facilitate the exchange of such information. And we do this by providing usable information on health service innovations and quality improvement tools on our website, which offers a searchable database of service delivery and policy innovation profiles and other content, such as attempts at innovation, stories from innovators, and commentaries by experts. The site also includes articles and guides about the processes of innovation and adoption. For example, on the articles and collections area of the site, you can find a guide to innovation adoption. Will it work here? A decision maker's guide to adopting innovations. The Innovations Exchange also offers learning and networking opportunities, such as virtual and in-person meetings, web events like this one, and more recently, learning communities. Which brings us to today. Because in 2014, AHRQ modified the scope of the Innovations Exchange, moving away from the program's previous focus on building the content collection and instead focusing efforts on supporting the adoption of innovations by sponsoring 3 learning communities, which we abbreviate LCs, on high-priority topics that you will hear much more about today. In addition to leading to meaningful change in care delivery, AHRQ sought to learn more about how to foster adoption and implementation of health service innovations through the use of these communities. We don't have time today to demo the innovations.arq.gov website to focus your attention on the work of the learning communities. Instead, this slide shows a screenshot of the learning communities homepage. From this page, you can access each individual learning communities page for more detailed information about each of them. We have also made available information about outcomes of each learning community and lessons learned from the Learning Community Initiative. We wanted to apprise you, in case you had not heard, that with funding and leadership changes at AHRQ, we have decided to take some time and think strategically about the future of the Innovations Exchange. The current AHRQ contract for the Innovations Exchange ends next month, September 2016. You'll hear from the learning communities about their next steps and intentions for sustainability, if any. To capitalize on past investments, however, we are planning to transition the innovations.arc.gov website from our contractor, Westat, to AHRQ's Office of Communications. And that group will assume responsibility for the website. With that said, please note that while content will remain accessible, it will not be updated until we, AHRQ, make a programmatic and strategic decision about the future of the Innovations Exchange. So with that, let's get going. I'm pleased to introduce today's moderator, Dr. Lisa Simpson. Lisa is President and Chief Executive Officer at Academy Health and has served as Chair of the Innovations Exchange Expert Panel for the last 5 years. Thank you so much, Lisa. A nationally recognized health policy researcher and pediatrician, she is a passionate advocate for the translation of research into policy and practice. Her research focuses on improving the performance of healthcare systems and includes studies of the quality and safety of care and healthcare disparities. Off to you, Lisa.
Thank you very much, Mary, and thank you also to AHRQ for your leadership in supporting this important work in the Innovations Exchange and its next phase around actually using the innovations to implement them in communities. So I'm going to give you a bit of an overview of the Innovation Exchange learning communities and introduce our fantastic speakers today. Next slide, please. Now, the Innovation Exchange defines a learning community as a select group of potential innovation adopters and stakeholders who interact and engage in a shared learning process to facilitate adaptation and implementation of innovations featured in the exchange. And the participants in these 3 learning communities that you will hear from shared experiences and learn from one another about their implementation journey, as well as receiving ongoing insights from both AHRQ innovators and content experts. While a common collaborative learning approach was applied to the 3 different topic areas, the various innovation strategies ranged in care settings, patient populations, and care processes. This approach provided AHRQ and all of us a unique opportunity to compare and contrast the experiences across these 3 unique learning communities. Next slide, please. You will hear much more from each of the learning community champions, but in brief, the 3 communities are listed here. The first one is one focused on patient and family-centered care in Florida, where members actually agreed to adopt one single innovation across the sites, as well as additional optional strategies that supported advancing patient and family-centered care. The second community focused on reducing non-urgent emergency services in the Detroit metropolitan area, aimed to solve the common community challenge and relied on innovations for inspiration and ideas, but did not formally adopt one specific innovation. And then the third community, the medication therapy management community in Houston, was formed specifically to implement and monitor an implementation pilot of a particular innovation. Next slide, please. The speakers for today's event include the 3 champions of the learning communities and the program's evaluator. First, we're going to hear from Beverly Johnson, who is President and CEO of the Institute for Patient and Family-Centered Care and is the expert champion for that community. Bev has provided technical assistance and consultation for advancing the practice of patient and family-centered care to over 250 hospitals and health systems, federal and state agencies, military treatment facilities, and other community organizations. Our second speaker will be Dr. Herb Smitherman, who is the Vice Dean, Wayne State University School of Medicine, and is the champion for reducing the learning collaborative around non-urgent emergency services. And he served also as a member of the Innovations Exchange editorial board. Dr. Smitherman has spent the past 24 years as a practicing physician working with diverse communities in Detroit to develop urban-based primary care delivery systems that integrate the health and social goals and community needs. And his research focuses on health issues related to underrepresented and underserved populations and their access to appropriate health care. Our third speaker is Dr. Joy Alonzo, who is a clinical assistant professor at the University of Houston College of Pharmacy and co-chairs with Dr. Aisha Moultrie the Medication Therapy Management Learning Community. Dr. Alonso has established clinical pharmacy practices and innovative patient services in internal medicine, psychiatric, and pediatric specialties where she develops, implements, and evaluates translational research outcomes. In her current roles, Dr. Alonso performs comparative effectiveness research, drug utilization review, and evaluates healthcare disparities in Medicaid pediatric populations. Our final speaker before we turn to the Q&A session is Dr. Russ Martin, who is the lead evaluator for the exchange and the innovation communities. Dr. Martin is the Associate Director at WestStat and led the evaluation of these three communities. In earlier work on the project, he was managing editor of the Innovations Exchange and directed the development of innovation profiles and quality tool summaries. Thank you to each of you for your time today, and I'm going to start by turning the program over to Bev.
Thank you, Lisa, and it was just an honor to participate in the patient and family-centered learning community with WestStat and all the participating hospitals from Florida. With this particular learning community, the challenge that we were addressing is to further the implementation of patient and family-centered care. And that the learning community embraced a shared definition. I think it's clear to establish the focus of all of the work. And patient and family-centered care, as defined in this learning community, is an approach to the planning, delivery, and evaluation of healthcare that's really grounded in mutually beneficial partnerships among patients, families, and healthcare professionals. There are four core concepts that are part of this framework: respect and dignity, information sharing, participation, and collaboration. It also is very clear that partnering with patients and families can lead to measurable improvements in safety and quality. But even with a great deal of understanding about this, it's been challenging for hospitals to really take those core concepts and integrate them in how the work is done in very concrete and meaningful ways. The aims of this learning community were three specifically. One, to engage the stakeholders in using evidence-based patient and family-centered framework that addresses leadership, patient and family partnerships, staff engagement, and performance improvement. All of those were central in the way the work was done in this learning community. The second aim was that the learning community really would assist hospitals in tailoring and implementing strategies from the Innovations Exchange. This is not just taking an innovation that someone else has been successful with and just replicating it exactly, but it is really thoughtfully tailoring it, recognizing the culture and context of each individual organization. And the third aim was to really achieve and document both improvement in process and outcome measures that related to each of the innovations that were implemented during the learning community. So our membership in this learning community, we had 11 Florida hospitals that really represented a very significant proportion of the population in Florida. 10 million people they served, and 50% of the population. I think the team, the members participating in the learning community were really senior-level managers and leaders, the quality improvement director, a C-suite member, patient experience coordinator, patient advocate, head of the advocacy department within an organization. This was key to some of the work. And then I served as an expert, a faculty member, Bernard Roberson, who was actually the innovator featured in the Innovations Exchange, participated in a lot of this work of the learning community, and then a wonderful partner was the Florida Hospital Association. And I think their involvement was important into launching the learning community and now in sustaining it. So this was important in the way this learning community was designed. So basically what happened in this initiative was that hospitals worked together to adopt and implement patient and family-centered strategies that were described in the Innovations Exchange. There were a number of these, and all of the all of the members of the community worked on one of those innovations, and that was they either developed or expanded their patient and family advisory program. Everybody did that, and they used many of the concepts that were described in the Innovations Exchange from the work that was done at Augusta University Medical Center. But I think certainly what the benefits of the learning community participation gave these hospitals that were committed, their leadership was committed to advancing the practice of patient and family centered care. And this learning community provided an opportunity so they could learn and augment their advisor programs. They could also learn about how to adapt specific patient and family-centered best practices and strategies in their environment. A key feature was that they shared lessons learned and the benefit from each other's. And they received guidance from the whole team, each other, and the experts that were brought together to really address barriers and challenges. When you look at outcomes, there were 7 new patient and family advisor programs. We started the initiative with 4 of the hospitals having patient and family advisory councils, but they wanted to expand how they were involved in much more meaningful ways. There were 73 new patient and family advisors across all 11 hospitals that were recruited and oriented and involved during the learning community. And the hospitals adapted a range of additional patient and family-centered strategies, not just having an advisory program. And these included really changing the concept of families as visitors to creating a 24-hour welcoming policy where they support and welcome the presence and participation of families. Another was really helping to educate staff across disciplines in what is patient and family-centered communication and how to do that effectively and integrated in the way they do the work. Another innovation was use of a communication notebook. And in the last year of the project, the patient and family advisor rounding was an evolution of this work where people had built the trust in patient and family advisors to begin to implement that innovation. So here you can see a graphic depiction of the progress that when we started in September 2014, there were 4 patient and family advisory councils, and then in June there were 11 across the 11 hospitals. The growth from 56 advisors to 129 advisors across these 11 hospitals. I think another important part of this learning community was to use an organizational self-assessment tool that looked at patient and family-centered practice. It was an adaptation of one that we had developed for Better Together, partnering with families, and looks at key domains that shape organizational culture. So, for instance, and I think it's exciting to report that there was progress in each one of these domains. So that's showing shift in organizational culture from November 2014 to June of 2016. In leadership, we were looking in this organizational assessment for are the core concepts of partnership and patient and family-centered care reflected in the key documents of the organization, in their vision, mission, philosophy of care? And, are leaders really modeling this in both their words and action? so that you see partnership lived in the organization. The second one, patients and families' participation in care. Are they really seen as essential members of the team and included and encouraged to be included in practices such as nurse change of shift and rounds, that families are no longer seen as visitors? And then human resources. This is key, that we build the concepts of patient and family-centered care into the job descriptions, performance evaluation, the hiring practices, the continuing education practices, and there were many changes and improvement in human resources. And the last, you can see the kind of growth in having patient and family advisors really a central part of these organizations. The kinds of partnerships that I mentioned some of the ones that were implemented during this learning community, but there are still others. And, you know, they partnered with patients and families to revise discharge packets so they would be more useful to patients and families. You know, really important issue in today's healthcare. A wonderful advisor at Broward Health shares his story as part of orientation. And there's so many details covered in orientation, but what people go away with is his story and how people interacted with him in a respectful, positive way. In other words, in a patient and family-centered way. At Cape Canaveral, with patients and families, they revised the patient handbook. Again, this sets the stage for partnership throughout a hospital stay. At Health Central, they have redesigned admissions paperwork and really developed some wonderful checklists and guidance for setting the stage for discharge right from admissions. And they are one of the ones that worked with advisor rounding. Jupiter Medical Center also had family rounding, and they developed a new hospital-wide patient and family-centered policy, a way for leaders to say, this is important, and it's going to drive how we do the work. It's not always asking people to do more, but it sets how work is done. And lastly, at Sacred Heart, they worked on developing a communication notepad that was described so well in the Innovations Exchange. And then they also did a review of hospital policies to look for how inclusive were they and respectful were they for the LGBT community. So those give you a range of some of the other ways that they did. In terms of how did the learning community help facilitate change? I think the key strategies were really four. One was the monthly networking and education webinars that were very participatory. They had a chance to talk to the faculty experts each time, but they also had a chance to talk to each other and to share both what was successful and what was not, and to ask for questions. I think another critical success factor in learning strategy was having the monthly coaching calls with each hospital. WestStat staff met with leaders of each one of these hospitals to explore how progress was moving along and if people were stuck, and to ensure that there was real accountability. And then I think another was that there was a SharePoint site that everybody could share their tools, and this was maintained and updated periodically. And then lastly, we can do all this work at a distance and be quite successful, but the power of getting people together at least once a year was really palpable, particularly at the last session when we had in-person meetings each year, and when patients and families were involved in more significant numbers in the second in-person meeting. You could see that people really began to understand, and I think it helped really move it forward even more significantly than we had in the past. Another way that change was facilitated was the use of the Innovations Exchange. It clearly saved us enormous amount of time to be able to point people to a thoughtful review of an innovation and how to, not to implement it exactly, but that they could adapt it to work within the culture and context of their organization. But we brought in some of these innovators as part of the webinar discussions they just learned so much, and there were tools and templates that would enable them to make this work. And having Bernard part of the series all along was very helpful. And then the learning community membership brought together, we had unique characteristics. They all were from hospitals. They were from similar departments. I think they built trust. They all dealt with similar issues, so it was easier to establish trust and be transparent. And then at the end, they developed a guide jointly, all of them together, to how to orient new patient and family advisors that is now available that I think would be useful to others. And I think just, you know, in summary, the key lessons learned that the commitment of senior leaders is absolutely crucial to organizational change. I think the second key point is it's essential to have someone in the organization with dedicated time to work with patient and family advisors and to have the skills that of flexibility and trust building to make that work. And that the leadership needs to understand that change in organizational culture takes time. So just in a parting word, meaningfully involving patient and family advisors in hospital QI efforts improves the patient experience and contributes to important changes in organizational culture. And now it's just a delight to turn this over to Dr. Herb Smitherman and for you to hear about his exciting learning community.
Thank you very much, Beverly. I appreciate the transition. My name is Herb Smitherman. I'm at Wayne State University, and I am involved in reducing non-urgent emergent services learning community. Let me just say this was, I think, a great experience. I was on the Innovations editorial board and helped to assemble the Library of Healthcare Delivery Best Practices and help the Agency for Healthcare Research and Quality through a process of identifying and assembling essentially a library of healthcare delivery best practices and policies from around the country. And if our country, if we are going to improve healthcare outcomes, we need as a country to be able to build best practice databases and share this information among each other for the purpose of adopting sort of best practices. So I looked at this whole AHRQ Healthcare Innovations Exchange as 3 stages. One is identify and assemble the library, and that is the best practices. So put it all together. The stage 2 is to promote and share and exchange these best practices across the country towards improving care. And stage 3 is what you are seeing and what we are talking about today, and that is actually supporting the adoption, scale-up, and spread of these best practices and utilization of the library towards improving healthcare in this country. Our emergency, reducing non-urgent emergency services learning community representatives were a collaborative of local leaders, that is Detroit stakeholders, and also national stakeholders, including AHRQ staff, WestStat staff, national experts, and a local set of stakeholders called the Voices of Detroit Initiatives. And the membership of that initiative is of these community stakeholders is below, which included the EMS services, our public health department, our mental health authority, which is involved in supporting the mental health services for the entire county, all the FQHC centers, our federally qualified health centers, our Detroit East Medical Control Board, which oversees all emergency services in our community, Detroit Area Agency on Aging, which services all senior services within our community, Neighborhood Service Organization, which serves the underserved, our hospitals, and Wayne State University. The challenge we had, and what are some of the drivers for this change, started with the mayor of the city at that time in 2012 indicating that EMS had an annual deficit of about $11 million. And at that time, this city was trying to get all of its public debt under control. And the mayor reached out to community stakeholders to come together to help solve this, what he considered a community problem. We had significant non-urgent, non-life-threatening calls and utilization of EMS for those non-urgent calls. In 2015, we had about 1,216 calls from super users, which we defined as 5 or more calls within a 12-month period, and we had over 18,000 non-urgent calls, and this was probably reduced. This was probably double what you see there in 2012. And these non-urgent runs were costly. They diverted resources from true emergencies. They increased EMS response times and clearly contributed to EMS budget deficits. We also had a large number of calls from a very small number of what we call hotspot locations. I'll talk about that in a little while. And then there was really no coordination between emergency services and the emergency room, and then the community-based primary care, mental health, social services, and the substance use infrastructure in the community. Just an example of some of the 911 calls we were getting that were considered and designated as non-urgent. You see here it's quite simple: boils, rash, sleep difficulties, STIs, toothaches. I ran out of medications. People were calling for transportation needs, minor abrasions. People were calling just to talk. We had a lady when I first started out that called at least 30 times in a 3-month period of time, and we sent a social worker out and found that her husband had just recently died. She was significantly depressed, and she was calling to talk to someone. After we got her some support services and counseling, her calls immediately stopped. So we moved from a person calling 911 30 times in a 3-month period and getting an ambulance out to eliminating all of those calls with actually just addressing the person's basic needs. The aims of our learning community were quite straightforward. Number one is identify who these high utilizers are of emergency service and develop an effective delivery system that addresses whatever their health care and social needs are. Number two is to improve coordination between the emergency services, primary care, behavioral health, social services, and senior services. And how we did that is through implemented protocols that were agreed upon amongst the stakeholders. We established and allowed EMS to make real-time referrals, which was not happening initially, and EMS responses to 911 calls, and they suspected that the caller's condition was non-urgent and or the caller is in need of additional health care or social services. They used their EMS electronic health record. They captured their perspective of the patient's caller's health or behavioral health issue or service or social service need using a pre-established drop-down menu. EMS indicated that the patient can receive additional support from the community agency. The patient is given a choice to opt out of the referral process. EMS documents in their EMS or EMR, which was called Safety Pad, the patient's willingness to be referred. EMS initiates a referral through Safety Pad. The Safety Pad system automatically determines if the patient who's referred is either age 60 and above, and it went to one organization, and 59 and below, it went to another. And this was automatic within the field. We also provided similar services to what we call the top 25 super users for 911 calls. These are people who are calling more than 5 or more calls in a 12-month period. And we also identified hotspot locations where there were significant numbers of 911 calls. And we explored strategies to connect patients at these hotspot areas to appropriate care. So the key steps and processes were really about connecting and coordination between emergency services, primary care, mental health services, substance use disorder, and social services. We built on ongoing efforts of Detroit EMS and fire, which was critically important. We didn't want to come in and usurp. We wanted to work with the framework that was currently in place. We shared data, which was critical. We leveraged strategies and innovators from the AHRQ Innovations Exchange. And we obtained consensus on strategies amongst the stakeholders. We obtained agreement amongst our stakeholders and developed and implemented policy and protocols that were agreed upon amongst all the stakeholders, including EMS and fire. Our outcomes, we had top 10 Detroit hotspots were identified. To our surprise, almost 60 to 70% of those hotspots were senior housing. We got Detroit Area Aging, Agency on Aging out to every one of those senior housing hotspots, and they engaged the entire housing complex, and those that were identified as calling and those that weren't identified as calling. We actually had many fewer 911 calls during the time when clinical services were available at one of our hotspot areas, which was a neighborhood organization for the most indigent and hard to reach. And we put a nurse practitioner, and we found when we put the nurse practitioner at the site, the calls went down to almost zero. And when the nurse practitioner was gone, the calls went back up to what their usual density was. And so clearly placing clinical services at the site to address basic health care needs decreased 911 calls. We also had almost 300 EMS referrals. When we instituted this program, the needs identified included dental, utility assistance, transportation, meal on wheels, chore helpers, visiting physicians, all kinds of needs, both social and non-social, and we got those needs out to the persons, and the 911 calls went down significantly. In fact, we had no super users age 60 and above since May 2015 in this given this program. We also were talking about sustainability, and we worked with our local oversight for our emergency services, and are transitioning all that we're doing in this collaborative as a advisory committee of the local oversight, statutory oversight for emergency services called Detroit East Medical Control Authority. We also, what is clear is that we utilize local and national experts, which was, and I'll just end it there, which were critically helpful with respect to developing our protocols and models. What was also very important is having dedicated infrastructure. We had lots of stakeholders and lots of people at the meeting, and we had monthly meetings and subgroup meetings and subcommittee meetings to keep all of that coordinated and orchestrated and executing the meetings and assembling all the resources. WestStat and AHRQ were critically important for continuity and sustainability of the process. Lessons learned, we clearly identified the needs and priorities of all the stakeholder organizations, which was critically important. You have to do that early on, and you reassess on an ongoing basis. Set the table with all the relevant stakeholders and keep revisiting member composition. It's important to identify all relevant local resources and be very inclusive. The learning community infrastructure provided us stability and enabled progress, especially when there were changes in stakeholder organizations. We had a lot of documentation along the way of what we did, so when new members joined, we provided them the documentation, and we never had to revisit where we had been in this process. And having data is critical in driving change. This means not only identifying what data is needed, but sharing data across different entities. Also, there were barriers inherent in touching this population. One thing we did learn is that even though we had the ACA and we were covering people, what we were dealing with especially emergency services and first contact services, were really the most hardest to reach and most recalcitrant part of our community. And access, clearly is important, but reorganizing the way we deliver services for this very, very hard to reach and hard to touch population is still an ongoing struggle, but we are doing much better in the redesign of our system in order to better care for this population. Also establish a sustainability plan as early as possible and work on that in tandem with your process. And emergency services, I think in conclusion, our emergency services learning communities cross-stakeholder collaboration facilitated system change and improved our delivery system. And it did that because we first identified best practices and innovators within the country using the AHRQ Healthcare Innovations Exchange database. We identified those in the country that were doing this kind of work and doing it well. And we called upon them and worked with them, and they advised us on how to best facilitate system change and improve our delivery system. And so we went from identifying, best practices to sharing across these different innovators their best practices and what they had learned, to adoption of what they did and scale up and spread, and it worked.
Hi, this is Dr. Joy Alonzo from the University of Houston, and I'm going to be talking about promoting medication therapy management for the at-risk populations, the MTM learning community. So hello to everyone from STEAMY Houston. Next slide, please. As you can see from this chart, the MTM learning community consisted of a very varied collection of clinicians. All groups represented were in various stages of planning, implementing, or executing an MTM project, so they were all very passionate about MTM services. This innovation project is a little unique in that a subset of the actual participants in the LC were actually performing the innovation, while the rest of us were actually watching and observing and monitoring the intervention, not unlike med students in a surgical observation theater. So you can see that there's a lot located in Texas, but there were a number of other geographic locations. And again, all these individuals were in the process of standing up or actually executing MTM services of their own. And this is very important in that there's a lot of literature suggesting that MTM services are very, very effective in affecting coordination of care between different services relative to medication, improving adherence, improving clinical outcomes, but there's very little written about how to actually stand one up and how to address challenges in your new clinical services. When we went as a group, we were able to discuss aspects of all the MTM interventions that we were all a part of and what was common to all, and discuss the challenges. Next slide, please. So the MTM LC project focused on patients with the following characteristics. They were all socioeconomically disadvantaged and uninsured patients who were eligible for services at an FQHC, which means they were all uninsured. The patients were adult, primarily Hispanic, and identified as at risk for poor health outcomes. They all suffered from type 2 diabetes mellitus and were targeted for the pilot intervention because they had uncontrolled clinical markers, such as an unacceptable level of A1C. The aims were very specific to this population and specific to the goals of the pilot intervention and the MTM LC at large. Next slide, please. One of the key activities was developing an LC charter that we all agreed to. This helped solidify our goals of the LC and to address the needs of all the participants. We identified that regular monthly meetings were also very important to this LC, so we could discuss the pilot and the results and identify the challenges and issues that were associated with the pilot. We were able to solicit experience and strategies from the LC membership, and the LC members were able to relate the topics that we discussed to their own MTM efforts. The monthly Voices from the Field program highlighted the other LC member MTM efforts outside of the MyRx pilot and allowed further identification of skills, tools, and resources that were needed by the whole group. The monthly presentations at the learning community, we identified the topics and leveraged the experience of the members' extended network. So even though we had the 14 entities identified, many, many more entities actually were drawn in to capitalize on their expertise. We also found it very, very important to conduct in-person meetings. We had 2 in-person meetings, both held here in Houston, and this gave a voice to many, many more people who maybe were not as prone to discuss individual topics on the monthly membership meetings. And we also are developing a case study that we're about to publish. And this summarizes the lessons learned and captured all the resources, and it kind of is like a how-to guide for standing up an MTM and challenges and issues. So the original MyRx medication adherence program was developed by Dr. Aisha Moultrie, she's an associate professor and dean of student services at Texas Southern University College of Pharmacy and Health Sciences, and her team, which included Dr. Uche Ndefo and Dr. Portia Davis. The MyRx implementation was developed to provide medication reconciliation and health education to seniors in the community in their homes. This had some limitations, which included lack of timely access to physicians if there was a pharmacist intervention that was suggested. So for the LC pilot, we decided to adapt the original MyRx, which is featured here on this slide, and tailor it to a clinic-based environment at the Spring Branch FQHC clinic, where we could capitalize on all the providers being in-house. So some of the key ways that the MyRx implementation was adapted for the clinic setting as opposed to the home-based setting were integrating the pharmacist into the primary care team. In this way, we could capitalize on pharmacists' unique knowledge of complex medication. We could help the physician optimize the meds across disease states, and we could impact outcomes by improving adherence, ensuring medication access, and overcoming barriers to obtaining medications in this population. We also modified the clinic workflow, and this was very important to a low-income person. Low-income persons have barriers such as transportation, time off from work, child care, and 2 separate appointments was just not going to be practical for this population. So we co-scheduled the appointments to allow for referral to the clinical pharmacy service immediately and trying to alleviate some of those barriers. Additionally, we found that facilitating interprofessional communication was a huge goal of the new MyRx clinic-based implementation, and this could allow for stand-up meetings or huddles of the pharmacist and the physician, and the physician could buy into the process, making sure that all the clinicians would agree on the medication recommendations and approach. So you can see some of the pilot outcomes here. The patients were identified for possible inclusion in the pilot from the Spring Branch FQHC clinic population of uncontrolled type 2 diabetics. So over a 6-month enrollment period, 57 patients were enrolled into the MyRx pilot program at the Spring Branch clinic. The average HbA1c of the patients at the beginning of the program was about 10.06%. Following the 6-month intervention period, 38 patients returned for a follow-up to the clinic. The average hemoglobin A1c of this group decreased by 8.53%, which represented a 15.7 reduction from enrollment. Additionally, there were some other parameters that improved. The average score on the patient medication adherence questionnaire increased, and the average score on diabetes knowledge questionnaire increased. Also, there were a total of 230 pharmacist interventions documented relative to suggested changes in the medication program for each patient. So these are some pretty impressive statistics, but the MyRx pilot did have some challenges. Enrolling the target number of patients from the originally identified pool was difficult because the patients didn't always understand the value of the program. They didn't understand why they needed to see another clinician at the clinic. And initially, there wasn't a strong enough partnership between the physicians and the pharmacists, and that's quite common in new NTM services. We also had issues relative to retention. Patients traveling in and out of the area. There was a high Hispanic population, and they traveled back and forth to Mexico, and they changed address, so we had a low probability of recontact. There was a high no-show rate, which is very commonly associated with the F2HC. And then coordination of the appointments was difficult. We needed a bilingual pharmacist, and that was difficult to obtain, and that impacted the number of days and times that the PCP and the pharmacist could coordinate appointments. So the challenges included the target number of patients, and we also had the LC membership observing.
We're going to shift gears quickly and go ahead to Dr. Russ Martin while we resolve some of the issues we were having with Joy's audio. Russ, do you mind going ahead for us?
Okay, thank you. I'm sorry for the technical difficulties, but we'll continue. This is Russ Martin, and I'm with Westat, the company that AHRQ selected to support the Innovations Exchange and these learning communities. And what I want to talk about for a few minutes this afternoon is a little bit higher level lessons that we drew from the experience of the learning communities, and talk a bit about forming and operating learning communities and about innovation, adoption, and implementation. So this project offered a unique opportunity to compare and contrast these three concurrent learning communities that applied a common collaborative learning approach to very different topic areas and innovation strategies across a range of care settings, patient populations, and care processes. Through our evaluation, we uncovered findings about the adoption and implementation of innovations that may be applicable to other learning networks. We identified lessons related to the startup of learning communities, their ongoing operations, and the innovation implementation process. So first, let me talk about the learning community startup. One of the most important things is the role of the learning community champion. And you've heard from the three champions already today, and I think have a sense of the important role of having a core thought leader and subject matter expert who can be the seed around which the learning community coalesces. The champion is someone who's known and trusted or a recognized expert in the field that brings the credibility and the opportunity for success to the learning community. Equally important is who is invited to join the learning community. And it is important to do an assessment to identify organizations that have a common problem and are at the appropriate state of readiness and preparation to be able to work together to solve that problem. And this approach keeps the focus on local problem solving and empowers the participants to develop local solutions based on the best available evidence. And so it's important to understand the organizational needs of the participants as the initiative begins. And so as part of that, Westat conducted a needs assessment early on in the life of the learning communities and use that to tailor the particular approaches for building consensus and adopting innovation. Next, once the learning communities were engaged and in operation, it takes a lot of work to get everyone involved and build the types of permanent collaborative relationships that it takes to make significant organizational changes. For these learning communities, we started by developing written charters that laid out the expectations of the participants and the goals towards which they were working. And then, in terms of how they work, that needs to be tailored to the needs and interests of the group. As you've heard, these three learning communities typically met through electronic webinars similar to this one on a monthly basis, but there was much additional communication in between those monthly group calls involving leadership teams and core groups, and in some cases, one-on-one participation and phone calls with the participants. And throughout that process, it was also important to hold at least one in-person meeting, and we found that was crucial for building group cohesion and allowing the participants to build the level of trust that's necessary to really work together. An in-person meeting provides a level of intensive interpersonal interaction that you really can't get any other way. And so we found that essential to hold at least one of those early in the life of the project. Now, every learning community experiences challenges. This is hard stuff. If it was easy, you wouldn't need to go to such an effort. And it's important to be aware that there are going to be ups and downs, and the end point is not guaranteed. And so we have found it helpful to be realistic and set realistic goals and to celebrate small victories along the way. And to be aware that not all organizations will have or maintain the level of interest or level of commitment throughout the life of the learning community. And it's important to be flexible and to work with the participants where they are and to enable them to contribute and to benefit as much as possible based on where they are in the innovation adoption process. Another important thing is to think about sustainability. Learning communities don't go on forever necessarily, and it's important to begin thinking about sustaining the types of process and policy changes that we're talking about right from the start. And part of that, of course, is financial, and it's important to understand and to try to demonstrate a positive financial return on investment for the innovation. However, even if the innovation change is successful, it may require continued ongoing funding. And one thing the learning community can do is provide a framework for collaborative thinking and shared effort at securing funding. However, sustainability is not entirely about the money. Sustainability is also about making the changes a normal part of daily operations and integrating them into routine policies, IT systems, and staffing and clinical workflows at the participating organizations. And so it's important to think about this right from the start. I want to talk next about a few things related to implementing innovations. And it really takes organizational buy-in, and then it takes sometimes difficult technical and clinical work to really make the changes. And so this takes time, and it's important to have the right participants at the table in the learning community over time, and that mix may change. What we found is that, especially at the beginning of the learning community, it's important to have the key decision members at the table. And you heard our champions talk about the participants, the executive level leaders at the participating organizations, and getting them to buy in and get their organizations on board. But then it often turns to more technical implementation decisions. Okay, how do we actually make these changes? What are the protocols going to be? And so that moves to a different type of collaboration, and it's important to document the value proposition at every stage and to structure the decision-making process so that the group can continue to make progress and not get bogged down over issues that might be particularly challenging. And by having those discussions in the collaborative framework of the learning community, that can result in more creative and effective solutions. Another interesting thing that every learning community that is working on innovation implementation has to consider is the trade-off between fidelity to the original innovation and the flexibility that's needed for local adaptation. And there's no single right answer for this, and you've heard different stories from the three different learning communities. You know, sometimes organizations need to have some flexibility for how they adopt things. On the other hand, if they stray too far from the source innovations and source evidence base that they're building from, then they may not necessarily achieve the improvements and the gains that they're hoping for. So that's just something to keep in mind as the work of the learning community moves along. So to sum up, learning communities really provide a rich collaborative environment, and a well-functioning learning community offers peer support and mentoring, and the opportunity for collaborative brainstorming, creativity, and problem solving. It helps newer or less experienced members avoid having to solve problems on their own, and it also holds members accountable, in a sense, by setting expectations, deadlines, and milestones. If somebody knows that next month they're on the hook to develop a certain aspect of the protocol or test some aspect of the innovation, they're motivated to report back to the group because of these interdependent and personal relationships. A key role of the learning community is to foster this type of collaboration and to aid in the development of protocols, policies, and tools. And certainly the innovations exchange is a valuable source of resources for stimulating this type of creative collaboration. So in conclusion, I would sum this up by saying learning communities engage, motivate, and accelerate innovation adoption. So with that, I'm going to wrap up.
All right. Thank you very much to all the speakers. And Joy, if you could just take a couple minutes of our Q&A time to just summarize really the key lessons learned from your really interesting learning community.
Yes, I would love to do that. So some of the key lessons learned were, well, it's true that the initial pilot included few patients. You know, it was a small cohort. We had hoped for more, but because of how we identified the challenges and issues in this implementation to the larger group, who all the rest of us were also implementing NPM innovations at the time, we were able to take the challenges and strategies that we identified for the MyRx pilot and apply them to our own NPM innovations. So in my own case, at the time when I first joined the LC community, I was developing a pediatric NPM program for pediatric asthma patients that were non-adherent. And one of the key skills that cut across all the NPM learning community members that we felt we were lacking in was motivational interviewing skills. So we identified that as something that we all wanted to improve upon, and we identified some key lecturers and key resources and key strategies to improve our motivational interviewing skills and incorporated that into our monthly membership. Spent a lot of time on that. Cultural competency was another one. that we spent a lot of time on. And I was able to take the skills that I learned through the LC and apply it to my own MTM innovation, and that is a much larger, had a bigger backing because it was associated with a health plan in the Medicaid population, and I was able to train 13 other pharmacies, 50 pharmacists, and during the period of time that I was involved with the MTM learning community, we performed more than 500 interventions with 500 different patients, 500 unique patients, and 500 interventions. So that was, the lessons learned was this had such a broad reach, and that by having this, turning the continuing education or postgraduate education on its ear and having it be learner-centered so that we actually as the community projected the next skill that we wanted to learn about because we identified it as a common deficiency or a common challenge or a strategy that we needed to incorporate. We identified it in the MyRx, but we applied it to all our own resources. So this provided this capability of watching and observing and monitoring another entity performing the innovation and then be able to apply their lessons learned to our own applications was really, really invaluable. It was a lot different than having somebody just get up and say, hey, here's how you do MTM. This was actually watching someone do it. So the extension to the number of patients, it's really difficult to measure, but you could see that it was exponential. So that capability to learn from doing that learner-centered environment and watching something as a real-world implementation was invaluable.
Wonderful. Thank you, Joy. That's really helpful. So we're now in full Q&A mode. Please don't forget to use the chat pod if you have questions. We're going to put that slide up again with the instructions, and then we are going to try to get to as many of them as possible. So I have a question for Herb, which is a clarification. Did the EMS make those real-time referrals in the ambulance, at the site, or once they brought the patient to the hospital?
The real-time referrals were made on site. So once the ambulance or EMS arrived on site, they would identify needs that the patient had, whether they were social needs or primary care needs of the caller, or whatever the additional health care and social service needs were, and they would capture that person's health care needs in their electronic medical record, push the button, and just based on the demographics of the patient, it would go to the appropriate service organization as a fax from the site.
Great. Thank you for clarifying. Bev, question for you. Could you tell us a little bit more about how each of the participating members in your learning community supported each other as they each implemented their patient and family-centered strategies?
Thank you for that important question. And, you know, I think at the beginning, one of the things that frankly scared some of the hospitals was just how do you recruit and how do you orient and how do you involve these advisors? It just seemed like such a big leap. And so it was really helpful to have some who were a little bit ahead who could demystify that. I think there's so many myths that if we bring patients and families to the table and begin to talk with them about working as partners with us in quality improvement and safety and enhancing programs, introducing new programs, that they will have unreasonable demands, it will take too much time, and by helping to see practical, one, to debunk those myths, and then to be able to talk it through, and they shared tools together, both at the webinar or they would post them in the SharePoint site. So it was wonderful to see that they weren't competing with each other, but they were willing to help each other out in very practical ways.
Great. Thanks, Joy. Another question that's focused on the patient and family engagement is related to the MTM pilot. So Joy, the question is related to so much of patient engagement tends to happen after the design of a project as opposed to sort of even before it gets started. So I wondered if you could tell us a bit more about patient and family engagement in the design of the pilot.
So the identification of the population is really, really important. In the MyRx implementation, we were focused on individuals that can seek treatment at an FQHC. So they are not eligible for insurance. They are not insured. They are, in most cases, not insurable. If you are insurable, the FQHC helps you get that insurance, and then you go seek treatment elsewhere. So we're talking about an indigent population that may not be citizens, and that's a huge feature relative to patient engagement in that particular population. So identification of barriers was key, and knowing that we had to have a bilingual pharmacist that was could identify with the community was key prior to implementation. Now, in another MTM, you have to really understand your population of individuals, who you're addressing, and the target disease state, and why you're addressing that target disease state. Does that make sense?
Yeah, that's great. Thank you. So we have a question which is a bit more general, and any one of you could answer. But we've heard a lot about what worked and some of your lessons learned, but just as important for our listening audience is, were there any specific mistakes that you either learned to avoid because of others' experience or that you made and corrected? But what's important to not do when you're organizing or facilitating a learning community? Anyone want to take that one on? Russ, since you evaluated all of them, go ahead.
This is Joy. Just like what you just had, that dead air, that's really tough. And for this web-enabled technology that we use to meet monthly, trying to engage people into talking was really challenging. So, you know, we had programming that we had an agenda and we had speakers, but how do you get people to ask questions, and how do you get people to actually really engage in the topic? And that was difficult. And the face-to-face meetings were really key in solidifying us as a team. The second year was much better than the first. So there was a lot more spirited engagement.
Good comment.
Joy, this is Bev, and I totally agree. I think we had some challenges in terms of getting people to talk on the webinars, and I think the in-person meeting does help with that. I think the other challenge for us was to help the hospital see that patient and family advisors and partners in this work were really welcome to participate in the webinar. And I wish we had been able to make that happen. They really should be part of designing the learning community and really at all phases of this innovation work. And I think in the future we would want to try to do that in more substantial ways.
I think one of the biggest, this is Herb Smitherman, I think one of the biggest challenges we had was continuously reassessing and identifying the needs and priorities of all the multiple stakeholder organizations. Everyone has agendas, and trying to keep those agendas addressing those agendas in a real way and keeping the collaborative together, giving the ebbs and flows of those multiple agendas is a very difficult task. You know, they talk about herding cats and for physicians, but this is actually worse. So I think that was our biggest challenge, and you have to really continue to reassess and re-engage and re-ask and have small group meetings and telephone calls and all of that to make sure you're keeping people on board. Because sometimes when you add an entity or a stakeholder, another stakeholder, it becomes problematic for another stakeholder, which is an interesting process.
Well, fascinating. Great point. Russ, a question for you. Were you able to examine any outcomes or health status or other outcomes and impact of the learning communities as part of this evaluation?
Yeah, thanks. So the three learning communities were very different in terms of the level of change they were trying to accomplish. For example, the EMS learning community in Detroit really was focusing on system-level change. And then the patient and family-centered care learning community in Florida was focusing on facility-level change and organizational processes. And really, I think where the patient outcomes were most impacted were in the medication therapy management learning community in Houston. And you heard Joy report on some of the improvements in A1C and some of the other clinical indicators. And I think that was really where we were able to document most clearly impact directly on patient outcomes.
Great, thank you. So there are a few questions that all get to sort of the back on the topic of the logistics and the intensity and the staff it takes to run these learning communities. Herb, you talked about how important the learning community was as sort of a stable infrastructure when stakeholder organizations came and went. But I invite any and all of you to comment about, you know, how much time and effort are we talking about here? Because this is critical for sustainability and really understanding the ROI. So I guess let me start with Russ. Did you do any estimates of the resource requirements for each learning community? And then we'll open it up to our learning community champions.
Yeah, and that's really a great point, Lisa, because this work does not happen on its own. It really takes not only an active and engaged champion, but staffing. You know, there's a lot of, as we've heard, phone calls and organization and planning and documentation and drafting of documents for the group to review. So it really takes a level of staff support. And through AHRQ, we were able to provide, I guess, not quite a full-time person, but more than half of an FTE for each learning community to provide this ongoing communication and staff support. And so that's a real level of commitment that's necessary to accomplish this type of work.
Thank you, Russ.
So this is Herb Smitherman.
Herb, did you?
I couldn't agree with Russ more. I can't overemphasize the need for dedicated infrastructure resources to execute the meetings and continue all the documentation it requires. The three aspects that I think are critical are, first, you have to have the infrastructure, and that is the actual innovations exchange library, some database that you can pull out best practices. Number two, you have to be able to access the experts within there, and WestStat and AHRQ were able to help us get access to those experts and leverage their expertise on our projects. And number three, just the literal meeting planning, the monthly meetings, the subgroup meetings, the telephone calls, and actually the WestStat and the AHRQ staff actually did some of those calls for us because they got to know the local stakeholders, and they were engaging the stakeholders directly.
Great. No, great points. Well, we are out of time for any more of the questions, and we have many more that we weren't able to get to live today, but there are questions about other resources available, which will be available on the site. Let me now first thank you, each of you, for joining us today, and thank our speakers for providing us with such a great summary and so many really important lessons learned that others can take and use in their own practice and improvement efforts. Please note that in approximately 2 weeks, all registered individuals will receive a link to the archived recording of this session. And finally, as you see here, please take a second to complete the brief evaluation about this webinar, which will be available momentarily. Don't forget to disabling your pop-up block. If it's right now, mine just popped up that my pop-up was blocked, so disable it and take the evaluation. And what's really important is we particularly appreciate your open-ended comments, which are always useful to us, AHRQ, and to WestStat. Thank you to all our speakers and to all of you, and have a great day. Bye now.